Screen sharing enabled, directing to our YouTube channel. Looks like we have about 20 folks. We'll give, I want to give one more minute, you think?
Okay. Okay, so we'll give 1 minute. Hello, everyone. We'll give a minute and then I'll come back.
Hi, Brad and Fatmata. Chris Petker here. I'm taking Mark Schaefer's place from CHA today, as he discussed with you.
Yes.
Hi, Dr. Petker. Nice to have you.
Nice to see you guys. Thanks for having us here.
Yeah. Tiffany, will someone be moving the slides?
That will be me. I can go ahead.
Okay. All right. Well, okay, good. Good afternoon, everyone. For those of you who don't know me, my name is Fatmata Williams, and I'm a Director of Medical Administration at the Department of Social Services and a co-lead of the bundle with Brad Richards. So I will give a welcome, and thank you for coming. We appreciate your time, but we also value your insight, your recommendations, and expertise that you bring as you work with us to develop this payment bundle together. I'll go through our agenda quick and give a quick high-level update, and we'll get into the meat of the presentation. So the agenda, we have a program status update. We'll talk a little bit about provider attribution, discuss the target price and case rate, discuss the reconciliation, and we will share the final quality measures and discuss next steps. Next slide, please. So we're still hoping to launch the bundle in September 1st of this year. However, there is the possibility that we may be able to launch it earlier than that. If we're able to do that, we will be sure to provide you all with 3 months notice before we do so. Our current priorities right now, we are working on getting a CMS approval for the bundle. We're also doing some actuarial modeling and program testing using our 2022 claims. And we're doing a lot of work behind the scenes, a lot of meetings to ensure program readiness. Some upcoming work, we will be drafting provider-specific case rates, and we will work to provide historic performance for specific providers. We're also working on provider bulletins, payment policies, and procedures. We will have some more forums and advisory council meetings. We are wrapping up a frequently asked document questionnaire, and we will be providing resources for lactation supports and other services. Next slide, please. This is just to give you an idea. I know most of you are familiar with this slide. Just to give a context here, the bundle itself is based on episodes. We have 3 episodes. The pregnancy episode has a look back period of 280 days. Then we have the delivery and postpartum episode. The postpartum episode has a look forward period of 90 days. And within the postpartum period, we will also be doing reporting on newborn care, which will be 30 days post-delivery, but 90 days maximum. There's also a reconciliation period, which will occur 6 months after we receive the delivery of the last claims. And services that are included in the bundle will be reconciled to a target price. So during earlier in the pregnancy, providers can bill fee for service because the case rate will kick in during the 2nd trimester. When the case rate kicks in, providers are still able to bill fee for service for certain services that are excluded out of the bundle, such as behavioral health services and DMEs. There's an exclusion list, so you can familiarize yourself with that. And then there's the reconciliation period, which will happen 6 months post-delivery after we receive the claims, and there will be shared savings and it will be upside only. We do have the 3 episodes, and the services are listed, as you can see on the screen. The pregnancy episode, you have services listed. Doulas are included, care navigators. Under the labor and delivery, we have vaginal and C-section delivery, and then the postpartum, there are also services that are listed. And I want to note that we will be collecting reports 365 days post-delivery to align with the policy DSS implemented in 2022 when we expanded postpartum care from 2 to 12 months. Our goal for collecting these reports is so we have enough data to inform whether we should include 1 year postpartum as part of the financial reconciliation after year 1 or further down in the bundle. Next slide, please. Okay, provider attribution. I believe I have to hand this over to Mercer, maybe, or you, Tiffany?
Yeah, I believe I'll take that one.
Okay. Yeah.
And this group is accustomed to seeing Grace Yang present at this forum, but we don't have her today, so I will present. I'm Charles Lassiter. I am the client point of contact for DSS on all of the maternity bundle work. I do have some of my actuarial team with me in case we do get into something that's a little more technical than I'm prepared for. But I think I can provide the refresher that this group has seen most of what we're going to present on today. So it's just going to be a quick walk back to talk about where we've gone with it since we last talked, and where we're planning on going with it in the future. So attribution, what you're seeing here is a bit of a new slide. It was a pivot that was taken a couple of months ago in trying to determine the appropriate group to participate in the program. We were running a kind of concurrent logic to try to derive where the cases landed in retrospect. We have changed that. And so now, in order to determine the participating group of providers that will be in the bundle, we're taking a look back and we're going straight through the claims and looking for the global codes you see in that stage 1. And then looking for E&M codes plus diagnosis. What that allows us to do is take a look back in the claims history and hopefully attach it to the more appropriate providers, and get us a more confident base in providers that will then receive the case rates prospectively as of the start of the program, when it does start. I'll pause at the end of these slides, and if we want to, Dr. Richards, we can dive into that particular process before moving on. It might be a little easier than jumping all the way back.
Sounds reasonable. And thanks, Charles. I was just going to highlight for the group as a reminder, one of the policy goals that we had all discussed previously is trying to have as many individuals attributed to providers as we could, as accurately could. And so that was part of this process, is to just make sure that we could attribute as many people as accurately as we could. And just wanted to remind folks of kind of why we went through this.
Okay, there are no questions. We can move on to the next slide, Tiffany. So I'll talk a little bit about the target price. The target price is really the cost that's expected for each of the provider groups during the participating year. In that, we've included the pregnancy, delivery, and postpartum care. We have excluded the newborn care that may be included in future years, but at the outset, the target price that'll be derived for each of the participants, that is the expected cost that we would have expected to see, will be derived based on the claims that come in under those 3 categories. And Tiffany, we can move to the next slide, and that'll get us a little further into the target pricing. With the target pricing, as you can see here, there's a list of criteria in which we'll include the claims. It's technical, and you can look at it later if you'd like, but in essence, we're going to be taking those claims that are incurred in the 3 trimesters, and we'll roll that into the target price, excluding some of the things listed in the above, a particular age bracket, a baby stillborn or miscarried, orphan, where we don't see a facility claim attached to the episode, But for the most part, we'll be taking all costs associated with the episode once it's attached to a provider, which I'll talk about in just a second. I can pause there. There'll be a little bit more discussion about how target price rolls into the shared savings opportunity that happens during a reconciliation period. But I'll pause there if there's anything that needs clarification or if there's question.
Going back to the attribution logic, in terms of the provider specialties that were listed, there were not maternal fetal medicine physicians. Does maternal fetal medicine fall under obstetrics and gynecology physicians, or are they treated differently because of the specialty care that they give?
I could touch that.
Yeah, go ahead, Charles.
Yeah, I was just to say in calculating the target price and then also the case rates that are derived, where the MFM becomes the accountable provider through means of continuous care, they have been considered an episode owner for those purposes. But where we can identify them as a consultative provider that has just come in to deal with a specific issue throughout the pregnancy, we have a means of identifying that limited use and then not attributing that episode to them. And then in the end, we are able to look back and see what the proportion of MFMs versus other, anything within the OB, and then be able to look at it a little bit and see in the attribution, right, which is just a retrospective look to categorize who might be the prospective owners of episodes, and so that we can take a look at it there.
So just to clarify, if maternal fetal medicine physicians are providing the prenatal care, doing the delivery, and provide the postpartum care, they are part of this attribution eligibility, or they're outside of this program?
They are, if they're providing those care, specifically if they are providing that prenatal care in the second trimester and then also delivery, they would then be an owner of an episode. And if they have enough of those throughout the prior year in our attribution look back, then they would be a qualified provider for the case rate and reconciliation, provided that they then actually live out the experience that we saw in the prior year.
Okay, thank you.
Yeah. And Tiffany, if there's no questions on target price, we can jump forward a little bit. And so this is a rather involved explanation of the target price, which is derived out of several different factors. It's basically the claims experience that's attached to the episode for that provider group. And then we do a couple of different things to try to normalize it or even it out for the disparity in risk that the different providers carry. We will look at both the statewide risk and try to normalize it to that, as well as a risk adjustment specific to the provider and the providers panels once we have the completed episode list. Once we have that, then we roll it into what's called the base price. And then the base price is also given another layer of risk adjustment based on the specific claims that we ended up seeing during the year. That risk adjustment will include things like claims truncation, where there's an outlier claim that would otherwise distort their target price versus their actuals, and that's part of the reconciliation process. That is to sum up all of that. What we'll do is we will try to insulate the variables that will cause the extremes during the historical pricing and the risk adjustment, so that the episodes can carry through at an expected cost relative to the different risk load or the severities within the panels of the providers that do end up capturing the episodes. And if all that sounds like womp, womp, womp.
Oh, you muted at the end there, Charles.
Oh, sorry about that. I was going to say, if that all sounds like jargon and technical speak, it's just a way to make it more fair for the providers that are participating in the end, and not have them subject to wild outliers and other things that might not be either within their control or something that they could have anticipated. All right, so for the case rate, Here we have a lot of the services that we've included in the case rate. This isn't all of them, but it's the large ones that you might see or be familiar with. On the left side, we talk a little bit about how the case rate payments will happen. They'll begin typically in the second trimester, but can also become triggered in the third trimester. Those case rates that are attached to episodes that happen in the third trimester won't continue on to the reconciliation, but the case rate will still be paid. The case rate is derived out of several different historical looks at claims experience, and then attached to different providers. Those we anticipate providing by the end of Q1. We've got the process now, but we're doing a little bit of cleaning and making sure that it falls within our expectations. And then also we'll work in the larger model. Dr. Pecker?
Great. Two questions related to this. I see that the services to be paid for under the case rate, for instance, in-house labs and in-house imaging, with large groups where you might have a community practice referring to a maternal fetal medicine specialist with under the same tax ID number, those services would be considered in-house, I would assume. But if a practice were to send a service like that to a hospital across the street, that would not be a part of their case rate. Can you just explain the logic behind that? Why we would be treating those very similar circumstances differently, potentially?
Yeah, I think the kind of policy and the programmatic logic behind that is that those labs and diagnostics that are sent out, we don't want to include in the case rate. We want them to be paid fee for service so that there's no hesitation to send it out, to refer it where necessary, right? There's no gatekeeper function on that if we don't include it in the case rate. So that's why the in-house ones are something that stays within the control of the provider and within the expected management of care. But where we see it being sent out and being referred, we don't believe that remains in the kind of scope of care for the provider or management or control, so that it's easiest to carve it out one of their case rate as well as their target price, the expected price, and then also include it when it is in-house so that they control it.
I'm sure you can see, though, it's a little bit of apples and oranges, though. It's the same referral habits being treated differently, though. I'm sure.
And it really changes the basic cost of the episode depending on whether that stuff is in or out.
Of the case rate, yes. And I think I may have misspoken. So the non-in-house labs and diagnostics are included in the target price and the reconciliation, but are not included in the case rate, which is the prospective payment. So that's, sorry.
You could just imagine, though, somebody really wanted to play the game. Yale could send all their ultrasounds to Hartford, and Hartford could send all their ultrasounds to Yale, and we would have a pretty funny game played there, just a sort of taking it to the extreme of trying to play the system. But it just creates that complex logic behind our referral patterns in an apples and oranges kind of way that doesn't seem quite fair, just with face validity from the users of the system.
In terms, can you elaborate a little bit more just to make sure I'm following the concern? Is in terms of at least how that's structured, it is trying to do what, if you're a practicing provider at this point and you currently do in-house labs, you want to make sure to include that in your current case rate. If you do that the majority of the time, that'll be included. If you are referring to another provider that's outside of your 10 for those services, for labs, for imaging, those will get paid separately as under fee for service because you're not currently including those under your existing cost structure. You're not getting paid for those and reimbursed for them.
Yeah, there's no incentive for cost containment if I'm referring out for fee for service for some of these services, whereas there is incentive for cost containment if it's calculated within my own internal case rate, if that makes sense.
Well, except for if it's your case rate, referring them out would exclude those costs from your future case rate. So the case rate would end up reflecting that, and you would dampen your own case rate. Whereas if you're referring them out for the target price and the reconciliation, whether you shift from having 90% in-house to 90% out of house, that's still going to be included in the reconciliation and the target price. So you don't duck the cost there. The only thing that you could do is potentially dampen down your case rate. And that might isolate you from some, cash flow issues, but in the end, it would be reflected. It may take a year to catch up. It's also something that we would want to look at. We will be looking at all those categories of services when we do look at the underutilization and the potential for underutilization and the other metrics as they come through. We will find the trends that move substantially, and if that's one of them, then I think we have to address the why, but won't know that until the actual performance year, which will move a lot of things around just by the nature of restructuring the delivery system.
And I'll just add that I think, the goal would be that, say that does happen in terms of, say you were doing all of your imaging in-house and you're getting your case rate that includes that, and you decide, actually, I'm going to send them all to Hartford. Well, I imagine, there's probably obviously that does include it in the target price as Charles said, so it's not like we're excluding it. It does still get included in some capacity, but we would then be looking at those metrics over, and as we update the case rate, and ultimately we are hoping that this kind of structure will help people to be able to say, okay, what's the totality of what's happening for our member? Obviously, the case rate will include a decent portion of of the total costs of care, but there's a lot that's falling outside of that case rate as well, that we imagine that providers who are trying to provide are able to, and hopefully this enables it to provide more kind of coordinated care that maybe historically has been hard to do, will have incentive to start doing that, which might mean, yeah, maybe I could send them to Hartford, but it's actually the best for the patient because now they're not going to get the imaging that I want them to do where I could do it down the hall. So I think,
trust me, we're motivated by that in the grand scheme of things. That's our primary motivation to
sure.
get.
No, I agree. As a provider, I understand, and I think you're just raising some of the concerns.
Yeah.
Reasonable that we should be thinking about, and we are thinking about, and I think it's important that we acknowledge them. So I just want to say that.
Right. The second and sort of related question to that is, what is the reconciliation that's going to be done in the first 1 or 2 years, given that there might be some massive changes in the landscape of practice, of the way offices and providers are practicing, given they're adapting to this model, and also to other unanticipated problems with the methodology, so that there's not a high risk that's being burdened by the providers in the state. What is the reconciliation that's going to be done to prevent risk from sitting on the providers related to those unanticipated methodologic problems and the massive changes in the landscape that might happen as practices try to adapt to this?
I'm not sure. We just need some more specification on the exact question there, just so I have a better sense of kind of the concern. Are you saying that providers are going to practice very differently because of it, or more because
you could imagine that there could be some potential unanticipated changes? Some providers wanting to opt out of Medicaid, for instance, because they don't want to participate in this. Other practice changes, like the hypothetical that I proposed earlier. These are sort of unanticipated things that might place risk on some providers who have unintended consequences of what those changes might happen. And how would this system absorb the risk on those providers for things you didn't anticipate and they didn't anticipate or have control over?
Yeah, and I think we've done that a couple of ways in the methodology. Tiffany, if you could go back one slide, we could talk a little bit about the Windsorization and the trend calculation. Those are both things that are meant to protect against anomalous changes in the system, like you suggested. For example, if there were if all of the labs started referring out and the price point changed on those because of the need to access that, we could find that spike in looking at the reconciled price. And that's where we would look at it there. For the case rate, The case rate is a debit against the target price. So it's essentially an advance payment on monies that are saved or used to develop the target price. So any shift that was unanticipated through use of the case rate, for example, if we paid for too many in-house labs diagnostics in your case rate, but they ended up shifting out so that there is a bigger burden on the fee-for-service system and less of a burden on the case rates for those services, that would roll into the target price and be a debit against that before anyone would access the shared savings that's derived from the reconciliation process, which has the historical price that's Windsorized, brought in to the 5th percentile and 99th percentile, I believe. And then we would apply the trends that we see year over year at that point, but including the performance year. And then we would get to some of the other things, statewide historical pricing, right? If we saw a hospital lab diagnostic category just jump threefold because there was a push to services, or the other way around, we would find that in the statewide historical pricing and the concurrent analysis of the performance year, and roll that forward to adjust to essentially level it out. So those are the process kind of protections that we put in place. After the reconciliation, there becomes the monitoring that occurs, and that is really, you know, category of service by provider types, looking at where the changes in the system happen. And then once we see something there, we would follow it back from a claims and a pricing perspective to see what effect they had. That again is a kind of retrospective past the first performance year, but that assumes that we have effectuated all of the pricing protections that we put into the case rate development and the target price.
And just to say, Charles, I think as you alluded to, there is risk adjustment built into it, so that if there was a into the target price, so there's clinical risk adjustment as well as adding some social risk adjustment through the area deprivation index as well, which were, and then there's the post, and then, you know, updating those case rates will also be occurring based off of utilization trends and patterns.
Thank you.
And here, like I mentioned earlier, we anticipate releasing case rates by the end of Q1 this year. A thing to note there is that the add-on payment for doula and lactation services is not part of the case rate. It is a add-on separate payment that's going to be occurring. The reason is so that we are able to exclude that from the reconciliation process, and deal with that separately. It's payment, it's recovery, it's accounting. In our negotiations right now with CMS, we are deriving the method to account for over and underuse of that, the doula services that are offered in the add-on payment. We are not completely there yet, but anticipate that we would have the idea of what CMS needs from DSS by the end of Q1 and by the time we release the case rates.
Oh, the only other thing, Charles, I just wanted to highlight, and sorry, the one before is just the one thing that we had discussed previously is, and I think may have wanted to make sure people had identified here, is that actually including the professional fees related to the delivery in the case rate. Before we had discussed not including those. But for various reasons, I think it makes sense to include it for the accountable for those providers that are attributed the case rate. They would then not get paid for, if they do the delivery themselves in the same 10, we get zero paid for those. If you are not the attributable provider, those would still get paid fee for service. So if you're with it outside of the 10, you would not get paid for those. Sorry, if you're outside the 10, you would get paid fee for service if you're not the attributable provider. Just wanted to note that and pause on that for a minute to see if there's any questions or comment on that, because that's since I think we last spoke, we haven't made that adjustment. And also just welcome thoughts on that later if anyone does want to bring that back up at any point. All All right, Tiffany, I think we can go forward, and thanks, Charles, for that.
Yeah, that's a good point, a good reminder. So the reconciliation process, it occurs no later than 6 months, and that is because we have to close out the performance years, the burst in the performance years, and then have enough data lag to be sure that we captured all of the claims costs that's in there. And then we will run the machine, which you see in the nice colorful boxes there. Target price minus the actual cost equals the net savings. And that savings is then awarded based on quality performance, and we'll talk about quality in the upcoming slides. Bundles will be reconciled once per year. We anticipate that there'll be a quarterly kind of data refresh that's given to providers to allow them to get a sense of the direction that they're heading, so as to give them a bit of a heads up on what the reconciliation might look like. So I'll pause there. The reconciliation really is just a taking of the target price and then the actual costs, and also including the prospective payments via the case rate. Okay, and here is just a draft reconciliation timeline. I won't speak much to it right here. You can go back and review it if you like. It's just how we are capturing the episodes within the performance year and prior year to derive the quality metrics, and then the time periods in which it will take us to reconcile all of that data and actually produce the results. This assumes a 7/1 go live, but at this point, we know that can shift to earlier or potentially as late as September 1. And for the quality measure section, Sean, if I can pass that to you.
Yes, hello. I'm Sean Thiel-Sachs. I also have Gabe with me, who will be chiming in when we talk about the visual representation example for the quality gate. I'll also go through these fairly quickly because there's not a lot of change since we met with you last time, but I will be pausing for just feedback and comments. So in particular here with the quality and measures and weights, the last time we met, we were discussing recommendations around the maternal adverse events. Those recommendations included a reduced rating from 18% to 6%. Since that meeting, that decision has been made. And so this is the final, most recent quality measures and weights for both pay for performance as well as pay for reporting. So this should not look new, but the decision around maternal adverse events has been made since the last call. So if we can go to the next slide. This next slide as well should look familiar. This really gives you an illustration of the concept of performance tier calculation and improvement tier. On the next slide after this, we'll walk through so you can see the 0 to 100% tiers more specifically, which again, I believe we shared last time. But the idea, I'm sorry, go back still. The idea is that the performance tier scores would take into account all quality measures, and the improvement tier scores would take into account only the pay for performance measures. Those then will come together to calculate a final score of the max of the performance score and improvement score. So in this illustration, the max here is 90% on the performance score side. So that is what would be pulled over into the final score. So if we now go to the next slide, again, this should look familiar, but this further spells out the methodology and the assumptions by tier. And so you'll see that the tiers allow from 0% to 100% from the raw data. And then based on where folks fall in those tiers will then input into the calculation and the percentage of earned shared savings. If we go to the next slide. And here, it was asked last time to try to give more of a view of how this then impacts the quality gate. And so I'll just give a quick tee up, and then I'm going to ask Gabe to go into a little bit more detail here. But we're really looking at performance from the current year, and then based on that performance, how that translates into the subsequent year to then feed into the shared savings results. So Gabe, do you want to go ahead and give a little bit more detail behind the visual, please?
Sure. I'll keep it pretty simple, I think. Really, the way it'll work is your first year, the current year, if you have an F, if you score an F based on the tables we showed above for both the performance and the improvement calculations, there is an improvement plan that the provider will need to provide. I don't know that I have much detail around what that performance plan looks like. I think it's still maybe TBD, but there'll be some plan in place. The subsequent year, if the provider scores F on both of these again, so the improvement is in the F tier and the performance is in the F tier, the provider wouldn't be eligible for the shared savings. So it's a 2-year process where if essentially bottom tier for performance and improvement two subsequent years, the shared savings goes away. That's really what this is showing.
And I'll just, Gabe, this is great. Thank you. And Sean, just to say again, kind of big picture in terms of like how we've approached the shared savings components, putting this quality program is to really try to incentivize both, reward those who are performing at a high level, as well as encourage those who may have opportunities for growth to grow and to reward both of those efforts. So, and that's how we've tried to structure this in a way so that providers in different places can still be rewarded as long as they're focusing on quality or maintain focusing on quality.
Can we go back to slide 18 if you're ready for questions?
Yes, go ahead. I was going to open it up and say, because this, as you see, we still have those 3 following slides as draft, and so reactions or feedback would be helpful. So go ahead.
Great. I'll have questions about a few of the measures on here. First, if we could go to the low birth weight, is this a risk-adjusted measure, or is this just the number of low birth weight infants in a practice? As a proportion of the total number of deliveries. So is this risk-adjusted? Is this for term infants only?
I don't have the specs in front of me at the moment, so I need to remind myself.
Yeah,
that's a great question. We have reviewed it, so I do have it. I just need to pull it so we can come back to
the reservations that some practices might have regarding this is that some practices take care of the bulk of hypertensives and diabetics within a certain region who will have a higher risk of growth restriction. And also some practices are actually the referral areas for growth restricted babies because those hospitals take care of the growth restricted babies. And there's concern that there'll be a attribution bias to those high risk providers and hospitals that will get punished for this metric unless it's risk adjusted or unless there's some sort of reconciliation of the risk that they're taking on by taking on these higher risk patients.
Chris, I've brought this up at every single meeting so far, and I've sort of a little bit given up. Low birth weight can be, associated with prematurity or growth restriction or whatever, and it's just a very nebulous measure. Bring it up once again, and thank you.
Yeah, I just had to get it into the public record.
Yeah, I know we've heard that from you all, from broadly about some concerns, and so I just want to say we have discussed those and
it actually represents really good care where higher risk hospitals or level 4 nurseries are getting these patients referred to and to penalize for actually good practices of care is a little bit discouraging.
And some practices, locations will automatically refer them, let's say it's prematurity, they automatically get delivered by another hospital or another provider.
Correct. Yeah.
I'll just note, and we have a spreadsheet that kind of helps us to review this, is that the MAE measure is the risk adjusted one. I know there's been concerns out that we've discussed previously about the maternal adverse event measure and how it's been being utilized. The other measures, and we actually went through a fairly extensive process of looking for measures, including having a consultant through Yale Core help look at it for us and then bring that to this group and discuss. So I think, in general, there's limitations with a lot of measures in terms of various risk adjustment features. And so I just want to acknowledge that those are concerns, also acknowledging that these are important measures in terms of outcomes that we've kind of collectively, especially in the DSS side, and I think with this group, acknowledge are important, though there are limitations. And I think there's honestly probably limitations with every single one of these measures. So I just want to say we will be open to continuing to talk about it, because we recognize that, one, I think measures will continue to be developed that are probably better than what we have now. And two, we recognize we're going to need to review this on a recurring basis to make sure that we're getting it right, so to speak.
Yeah, it's an unfortunate thing in obstetrics. We don't have better measures to measure high quality care, and as you point out, but these will be publicly available numbers, and these will be patients will be judging practices based on these things, and there's difference between an imperfect metric and a metric that really should not be used. And we do have problems with these metrics in the way that they might be attributed to practices in a somewhat unfair way. If we could go to the cesarean birth metric, this is the NTSV metric. It's not clear that it's the NTSV metric.
Yeah, the C-section birth.
And so with practices that do under 100 deliveries, for instance, how are you going to reconcile the fact that they will have a small number of patients that actually fit the denominator portion of the NTSV group? So it would be a small subset of their patients that would be in the NTSV denominator, and how random variances in practice might influence them being above or below 24% rather than actual practice patterns, and that the metric doesn't work at the scale that some smaller practices, even practices that do 100 or 200 deliveries, as we've seen in hospitals that do smaller numbers of deliveries across the country.
Just to clarify, the 24% is the weight of the measure in aggregate, not the actual.
Yeah, it just happens to be very close to what
the
national target metric is. So so the national target metric is 23.6 or 23.9, depending on who you ask.
Yeah, I mean, I'll just say I think again, like for several of these, and even obviously section, and I think this is one of the things that the maternal adverse events measure is trying to get to, is trying to reduce that small n variation that I think you're referring to, that can be problematic for especially small providers. So I just want to acknowledge that that is something that has to be considered and thought about as we look to hopefully have measures in the future that account for that, such as some of the newer measures that are trying to allow for these to be measured at smaller practice levels. So I think there is, I don't think any of us think that these are perfect. I don't think any of us are disillusioned or believe that these have perfect predictive power for all of these, what we're looking for. But I think collectively we know that I think there could be better outcomes. And so I think I feel relatively good about our starting place, acknowledging that I'm hoping over time we do have improved measures that do account for both for the risk adjustment as well as for small n variability.
Have you modeled this on last year's performance or the previous year's performance to have a realistic perspective on how these might look?
We have.
Yes.
In fact, we have a few slides that show the distribution of performance. I think it's at the aggregate level, but we do have the individual quality level data
by practices.
By practices.
Yeah, one of the pieces we're wanting your feedback on today is we're trying to put a dashboard together that looks at this information, and you can slice it in a variety of ways from the system level to down to the practice level. And we're wanting to make sure that however that is developed, that it's going to be useful, right? And so we have some screenshots to share today to give you some idea of what it could look like, and have begun to collect information and feedback. And so feedback you all would have on that would be great.
Would we be able to look at what the practice data for the last 1 or 2 years has looked like in these quality measures, so that we can see how some of the considerations that have been brought up over the last several months might look and might become problematic? Because and would there be a potential to suppress these measures if we haven't done the adequate foresight, where these measures might not be working in the way that they're intended?
So that data is available at the 10 level right now. We can let us go back and see what it would take to make that available at the provider level, and to dashboard that and make it available.
It might be helpful. I know you've used the Yale core consultants. They don't look at quality measures in obstetrics. The only one that they've worked on is the MAE, and that's a hypothetical metric that hasn't been used in practice yet. So,
and also to your point,
you have people in the state who have looked at these measures across practices who might be really helpful in giving advice on it.
And I was just going to say also to your point on, looking at multiple years, Mercer and CHN are working together to look at more than a 1-year snapshot. And so we have 2 fiscal years right now, just in terms of trying to run what it could look like. But I think that that's something that we could further explore to get a better picture of year-over-year performance.
And again, I hear what you're saying, Brad. I still, have to quote the line from The Princess Bride about low birth weight. I don't think it means what you think it means. So I don't think it's going to help us, particularly on the number 9, which I know it's only reporting breastfeeding. We talked about last time that we don't have very much control. Although if we can have prenatal lactation telehealth support, we might be able to steer that number a little bit, but usually that's up to pediatricians and hospital staffs, not obstetricians.
And just to point out, obviously we're starting as a paper reporting measure, so that's where it really will come in, is just whether we have data on it. I think that's all I'm saying that for now, but I appreciate the feedback. I know we're going to have to continue to revise this. I also will just say, in terms of the reporting out, I don't think we've said at like the 10 level, we would definitively be doing that. I think maybe in the aggregate, it's something we would want to take back. For OBP for P, we have not necessarily done that as part of the program. And I think there may be good reason for us to discuss making sure that we have this, obviously, aggregate data available, but you may not want to have it out as, I think, Chris, you were kind of alluding to, as a public data source that people can go and look at least as we're rolling this out. And I think that is something we can take back that may be helpful to hear.
Okay, were there other questions on the illustration slides? I believe you had mentioned you might have some questions or comments on that as well. No? Right, anything on the quality gate? All right, I'm seeing heads shake no. Okay, so if we can move forward. Here again, you've seen this before. This is another kind of draft representation to illustrate distribution of percentage of shared savings level achieved by the score type. This is looking at your performance tier versus your improvement tier, and then the final score calculation. So as you can see, just as a reminder, In this model, 59% of providers would earn 70 to 80% of shared savings at the performance tier. 59% of providers did not improve or did worse than the prior year. Distribution then of the shared savings, you're looking at the average earned shared savings at 74%. And then now a wider arrangement of shared savings ranging from 50 to 100 compared to the 70 to 100. And in this modeling, 6% of those providers obtained 100%. So again, this is draft. And this is, we're running the various models based on the tiered approach and calculation of shared savings. So I don't know if you have additional comments or feedback here. Like I mentioned, this slide has not changed. This is the slide you had seen previously. Matt, did you have a comment? I'm sorry. I thought I heard you. No? Okay. All right. So going to the next section, this is the dashboard we had talked about a moment ago, just to give you an idea of what could be captured. And understanding what slices of the data would or would not be helpful would be good for us to hear from you. Like I said, we're in the process of collecting feedback to determine how to make this as useful as possible. So one of the potential areas that we could represent and track is that percentage of earned shared savings. As you can see on here, we can do that as illustrated on the last slide, where we're looking at improvement versus performance tiers, and then the overall final shared savings calculation that currently is represented by fiscal year, and then the percentage tiers that we're aggregately falling into. If you go to the next slide. This was requested as part of the feedback. This is still not final, but we wanted to get you something to show what it would look like. When we demoed the dashboard a couple weeks back, it was shared that it would be helpful to have a place in the dashboard that defines what the quality measures are, including the measure, the description, the category, whether it's reporting or performance. In our case, not sure membership is needed, but that was an automatic pullover from the data. And then if there were any excluded members. So this is more of a resource option in the dashboard that came from feedback we received a couple weeks ago. So if this would continue to be helpful, this could be updated and finalized as those measures go into play. We can go to the next slide. This then is a brief snapshot of how we can begin to look at each of the individual members or measures. And as you can see on the left-hand slide, this is where I mentioned that we could slice the data differently. There are some options where you could do that by fiscal year. You could do it by the individual measure or group of measures. The measure, the TIN provider. And so this allows for, as Dr. Richards says, wouldn't necessarily be everything that would be public, but we could consider this dashboard to pull public data as well as be a tool to individual practices, if that makes sense. And so we can do this by, in a variety of ways. And we are just demonstrating here the different ways we can do that. We can do it by, the measure rate detail in the bars. We can do the dials there, or a plot diagram in terms of distribution and rate. So we can slice this data, like I said, in multiple ways. Your feedback on how that would make the most sense and be the most useful to you would be helpful. And then the next slide, this takes us into our next step. So we'll go back. I thought we had one more picture, but I guess not. So reactions or feedback, we want to be able to aggregate and pull the data in a way that's going to be useful.
Will practices be able to see other practices' performance, and will the performance be made publicly available?
So I don't think those decisions have been made yet, Brad. I mean,
Yeah, I was just
this,
gonna agree. I don't think we would ideally make other practices available. I mean, probably at an aggregate level would make sense, I would think, would be what we'd want, Sean, but I wouldn't imagine we'd want to say, here, you can go look at the clinic, the practice on the street. That wouldn't be, I don't think, what we'd look to be doing as of now.
Right.
Again, if we ever, at some point in the future, I could imagine it may make sense to have a very public reporting out of these things. But obviously, I think as we all acknowledge, we're rolling this out. We want this will take some iterative processes to get this right. And also we want to make sure that we feel very confident in the data reporting out. And so I think we're very much going to be aligned in terms of keeping this to providers, but also sharing probably aggregate data in terms of performance rather than at that provider level.
When you say aggregate, you just mean state level data?
Exactly, all the practices combined. Like what are the performance tiers? What's the 75th percentile? What's 25th?
Right.
Rather than at the 10 level, which would be at that provider. Again, I think ultimately that makes sense, but I think we want to make sure we're getting it right before we do that.
Yeah.
When would we hear an affirmative comment, official comment that this would not be publicly available at the practice level and it would not be shared across practices?
I will say we'll confirm that internally, but I think relatively confidently that we will affirm that. I think we'll take that recommendation and confirm that internally. But I would say very likely that will be our stance as of at least year one.
Yeah, I think with so many of the metrics being so uncertain in their validity and their applicability, particularly relative to practice size and practice location and referral patterns, that it would be really important to suppress this data for at least the first year because of the unintended consequences of the data being used inappropriately or perceived inappropriately.
And I'll just note, we really have tried to make sure that we'll be really thoughtful about how we're deploying this. And again, I think want to make sure we are getting feedback. And we definitely hear the concerns raised, and we'll continue to listen to them and look to be making adjustments as we move this forward.
and for the purposes of this visual, the bars on the left were not intended to be like, this is how it's going to work. This was intended to show the possible capabilities of how to slice the data. And it, as Dr. Richards says, it would be DSS's decision around to what degree something would be public or not. All right. So I think I'm handing it back to you, Dr. Richards, to talk about next steps.
Yep. Yeah, just our next step. So we are, and so many of you may have seen the request for public comment on the state plan amendment. I think we've received some feedback probably from some of you on this. We appreciate it. We are finalizing submission to CMS. We've had conversations previously, as Charles mentioned, with them about some of the preliminary draft SPA language, which has been helpful. And we're really working now to finalize the case rates, as Charles mentioned. We understand that's really important. I think I've probably said that in many meetings. And I just want to say we understand the importance of seeing those, as well as seeing the dry runs. That includes quality performance data so that practices and providers understand what that means. I will also note we are, this came up a little bit, but in terms of the dual implementation, we are continuing to work through this dual track where doulas can work with providers, but we're also working on a fee-for-service option so that doulas can become enrolled directly, and we'll be able to bill directly through DSS. And so those dual paths are in the works. Again, the fee-for-service one contingent upon DPH certification process being finalized, which we have been in touch with them and know that process is still in the works, but close to being finalized. We are also working on documentation so that providers have clear documentation about what practices we expect in terms of billing, et cetera. We do hope to make it as simple as possible on the provider side so that it's not a drastic change in terms of what people currently are doing. We are having a provider forum that is upcoming. We are, again, working towards making sure we'll be communicating this to more broadly to providers, and also expect to have another advisory council meeting as we get closer, probably in a few months, as we have more information to discuss. So especially if we have there may be, I'll just note, we may have feedback from CMS that requires us to make changes to some of this potentially, and we will make sure to bring that forward to this group if that happens, and especially with any recommendations that we have. And so you'll see, just in terms of the resources, there you'll note a few here. There's a dual DSS dual integration webpage. Again, we noted the draft case rates provider bulletins are in the works. Same with the historical reporting. We will, as I know, have the February 14th provider forum, and that we're working on a few other key documents around lactation and supports and other service guidance that we'll be putting together. So I'll pause to see if there are any other questions. I know, I think I just want to acknowledge we'll be planning on continuing to put information out. We want feedback. We anticipate that post-launch, we will be getting more feedback, and we'll look to include that and iterate on this over time. So let me pause, see if there's any other questions that folks would like to raise or comments they'd like to make. Hearing none, thank you all. We really do appreciate it. This has been recorded, so if anyone wants to watch this afterwards, feel free to share the link. It's on the CTDSS YouTube channel, where we also have the agenda posted. We'll also, on our website, have the materials posted as well. So again, thank you. Have a great rest of your Tuesday. And for those who want to join the provider forum, please feel free to. And Amy, I see your hand went up, so go ahead, and if others have dropped, that's okay.
Yeah, just really quickly, I would be remiss if I didn't add, along with Mike Seidel, that in order to influence the persons to breastfeed while they're in the hospital, it really requires a prenatal visit. So just adding that.
Thanks, Amy. Appreciate that. All right. Thanks to all. We appreciate the comments, the questions, the